everybody. I'm Susan Eichhorst. I'm a physician assistant here at Asana Health and Wellness. And today I want to talk to women who have not gone through menopause yet. This is our pre-menopausal group. Hormone balancing frequently comes up once we go into menopause, and we talk about bioidentical hormone replacement therapy for estradiol and progesterone, also adding testosterone. But many of the women that I see are younger than menopausal ages, and they're having many of the same complaints that menopausal women are. They are gaining weight, they're seeing more fat distribution versus muscle, they feel bloated, their breasts are tender, PMS symptoms keep getting worse, they're tired, and then they can't sleep at night, irritable, moodiness, mood swings, anxious, depressed, brain fog. All of these things are symptoms that we see in our younger women that can be hormone related. Other issues that come up are migraine headaches, low libido, heavy and very painful menses or irregular periods, certainly infertility and difficulty maintaining pregnancy and postpartum depression. All of these symptoms are frequently associated with hormone imbalances for women. Most conventional medicine techniques really talk about, they'll just accept this. This is normal for your age, you're getting older, and assuming that if you are still having a period, that your hormones are fine. Really what that tells me, if you're still having periods, is that you're making enough estrogen, but you may not be making enough progesterone. And frequently we blow off women all the time. Of course, you're tired. You have a career, you have kids, you have a husband. It's a busy life. Just get used to it. Everybody's tired. And then the pill becomes the solution for so many of these issues. And we will talk more about oral contraceptives as a contraceptive, which is very important for, but also as a hormone balancer, which I'm not as much in favor of when we have other options. And then, of course, we have lots of other pills for sleep, anxiety, depression, those types of things that frequently adding progesterone, adjusting the thyroid, getting a vitamin D level up, all of these things may be more beneficial for that woman than just giving her another pill. So as I started to allude to, integrative and functional medicine really look for more of a root cause. We want to find the reason on why you're having all these symptoms. Frequently, it's imbalances of hormones, estrogen to progesterone specifically, but also poor dietary choices. These can have a big impact on how our hormones work, how the rest of our body works around our hormones, and really our food choices make probably one of the biggest factors in our health. We cannot not think about environmental toxins as well. We regrettably live in a very toxic world right now. We have environmental toxins from our industries. We have toxins in our personal products, in our laundry detergent, in our cleaning products. We are exposed to many, many chemicals throughout our day. And so these can also affect your hormones and how your body responds to hormones. But frequently what I find, it's really having a low progesterone to estrogen ratio. And so adding natural progesterone can be just life-changing for some women. Before we go a little further, though, I want to just refresh what are hormones. So hormones are chemical messages that our bodies make. They use to communicate between different tissues in the body. Probably some of the most common ones that we think of, adrenaline, cortisol, insulin, these are short-term burst hormones. They secrete from the adrenal glands with respect to adrenaline and cortisol, and from the pancreas with insulin when they are exposed to stress, cortisol and adrenaline, and glucose, sugar, starch with insulin. They are designed to have a quick burst. In the case of adrenaline and cortisol, your adrenal glands kick in when you're crossing a street and you see a car coming towards you, you're going to just kick it up and get to the other side. That's your adrenaline spiking, that's your cortisol spiking. You get to the other side of the curb, you start walking slower again. Those levels are supposed to come back down. That's how they're designed. Insulin works similarly. You ingest food or a meal that has carbohydrates or starch in it. That insulin gets secreted very quickly because glucose is toxic to the body in high levels. It pushes that glucose elsewhere. That elsewhere is muscle and fat, and then that insulin is designed to come right back down. We will talk a little bit more about why it's so problematic when they don't come back down to normal and we get high cortisol levels and we get insulin resistance. The two main hormones that I'm going to concentrate on today, and really the one, is progesterone. But we have estradiol as well, and that can put us in kind of an estrogen dominant state when progesterone is low. Testosterone is a pretty important hormone for women. It's not just a male hormone. We now understand that certainly it has an interplay in muscular health, bone health, libido, but it's also essential for ovulation. So if a woman has zero testosterone, that is not appropriate for, it's necessary to have it for ovulation. DHEA is dihydroepialdosterone, and that hormone is really a precursor to testosterone, and I'll touch on that in a little bit. Lastly, we'll kind of, again, touch on thyroid and vitamin D, because vitamin D is actually a prohormone, not a vitamin, but kind of hard to change that term at this point. So again, hormones are secreted from one tissue or an organ and work by fitting into a receptor or an outlet on or inside the cell. And then that activates that cell to perform the duty that that hormone is triggering it to do. There are these receptors on and in every cell in our bodies. There are specific cells that have specific receptors. But when we talk about thyroid and the sex hormones, nearly all the cells have a receptor that can be activated by those hormones. So the female sex hormones, estrogen is probably the main one that most people are well aware of. It has three forms: estriol, estradiol, and estrone. Estriol and estradiol are the most healthful, and estradiol is the most prevalent, and that is what we use for hormone replacement therapy in menopausal women in this practice anyway. There are still some alternatives out there. That's left for a different talk. Estrone does have some physiological need, but essentially it is a metabolic hormone. So as estradiol breaks down to be removed from the body and excreted, that is the form that we make is estrone. Estrone is also the dominant hormone once women go through menopause and have lost estradiol being secreted from the ovaries. We tend to make more estrone, and this is probably a good reason why the rates of breast cancer go up after menopause, even if, especially when a woman is not on hormone replacement therapy with bioidentical estradiol. Estrogen tends to promote growth, so women will notice that their breasts get a little bigger, especially when they're in a more estrogen dominant state. Progesterone, on the other hand, is a hormone that is really designed to prepare the body for pregnancy. If you look at the name progesterone, progestational, that's where that name comes from. You really cannot maintain a pregnancy without progesterone, and it does help balance the effects of estrogen, so it's a little more calming. Testosterone is released from the adrenal glands and the ovaries, and women do not produce large amounts of testosterone, but we certainly respond positively to adding it as an additional hormone. And I do use testosterone for younger women. I don't think I have any women in their early 20s on testosterone, probably more 30s to 40s in my younger set, but it can be very instrumental in lowering anxiety and certainly raising libido. And then lastly, as a DHEA, that is a hormone that we make. It is the precursor to testosterone, and you can take DHEA separately. It actually has its own receptors, so it's really not just the precursor to another hormone. It is utilized on its own as well. And that is something that some women can supplement with, although it tends to have a little more side effect profile with our younger women, and I'll touch on that a little bit later. Just to help women kind of understand where they are in the spectrum, kind of the average age for menopause is still around 52 as an average, but many women start losing their progesterone way sooner than that, even into their 20s. Some women are not producing enough progesterone through their ovaries. Actually, the corpus luteum is what the little gland that produces the progesterone. And then we do see a natural progression and decline of progesterone between 20s and 30s, I beg your pardon, 20 and 40s, of roughly 30 to 50%. So that's quite a decline when we're still making a lot of estrogen. And that can cause this imbalance that I've talked about. Many women experience menopause early and in their 40s, and I've even known some patients and friends who have gone through full-blown menopause in their 30s. So just a quick review of menstruation. So menstruation, it comes from the word menses, which is a Latin term for month, and menstruus for monthly. And then the period comes from the period of menstruation. So that's that 4 to 7 days, usually that women shed the lining of the uterus. And in this diagram, it just gives you a little overview. The blue line is estrogen. This is obviously a UK English slide because they spell estrogen starting with an O. Here we drop the O, but estrogen is released and raises after the period, and that starts to rise down around day 14 when an egg is released through ovulation. Those estrogen levels start to decline a little bit. And at that point, you can see our progesterone rises and it gets even a little higher than estrogen. This is to maintain the uterine lining long enough for that egg to implant if it's fertilized. If that egg is fertilized, we now need higher levels and persistent levels of progesterone to maintain that egg in the lining until the placenta is developed, and then that will start making the bulk of the progesterone for women. So progesterone really has a very important role in maintaining implantation of that egg, and many first pregnancies are lost and thought to be genetic and now understood probably to be more related to low progesterone levels. So during menstruation, there's an estrogen to progesterone balance, as I showed. And what I have seen and what I've been taught is really these heavier periods that we go through anytime in our menstruating life, whether that's early, like myself at 15 with horrible periods, or very stable periods. And then in our 30s and 40s, things start getting heavier, a little more irregular. Those are frequently signs of low progesterone. I suffered menstrual migraines. I was put on the birth control pill for that, and it did alleviate them. But now I've learned I probably could have been helped with low progesterone, and that would have made sense with heavy periods. Not so much irregular, but the menstrual migraines that were really debilitating for me, and I know they are for a lot of women. So when we look at hormone levels, normal versus optimal, this is always a very curious discussion. I always like to remind people, and it's in the middle of the slide, normal is common. You know, being 20 pounds overweight is normal today. That doesn't mean that's healthy or optimal, but it is common. And so when we look at lab values, that's why some of these values are so variable. They are very wide. And one end is at a very low level and the other one seems very high compared to that. And those are both normal because that's what we find in the population. So when I see a menstruating woman, even if she's irregular, I don't generally check her estradiol or her progesterone. My training has really kind of taught me, hey, if you are menstruating, you are making estrogen. And it's very rare that I would give women more estrogen, or in this case, estradiol is the form I use, because they make enough estrogen to actually have a period and bleed and slough. They made that uterine lining and now it's sloughing. So really it's best to treat according to symptoms. And as I said, these normal ranges are common, but they're also based on a population base. Regrettably, as our population gets a little less healthy and we're not in very good shape now, those ranges may even change more because we're basing them on the population, not on what's optimal. So really, we want to look at the optimal range is usually what really refers to the levels that relieve symptoms and that have the best health outcomes. And those are not always indicative and within the range of what these normal levels are. So what do we do when we go to most traditional doctors for these complaints of, I think I have some hormonal imbalances, my periods are heavy, I'm super moody. What the common thing to do is to offer an oral contraceptive. This actually works for a lot of people. And it did work for me for my menstrual migraines. I didn't come off the pill. I stayed on it for 3 or 4 months. Then I discontinued it for a week. I had a shed. I went back on it. I also had a migraine. And then I went on it for another 3 or 4 months, kept my migraines at bay. But really part of the problem is it's suppressing the ovarian function, and then only circulating synthetic forms of this estrogen and progesterone are circulating in the body. That works for a lot of women, and many women tolerate the pill, but many women don't. They don't feel well. They don't like how their libido has been tanked. They don't like that they feel anxious, irritable. So the contraceptive pill is really not a placebo, or I'm sorry, a panacea for everybody. The other aspect of that is many of these contraceptive formulations are really just Provera. Provera is synthetic progesterone. It has a scientific name of medroxyprogesterone acetate, which I'm pretty sure was a very deliberate name because it gets very easily confused with natural progesterone, which it is not. One is a synthetic chemical that mimics progesterone enough to fit into that receptor and trigger the cell to do what it wants. Unfortunately, that's not always the safest thing to do, and we'll touch on that in a little bit. But these are the traditional models that we take, that we lean towards. And then again, many medications. Here's a pill for your depression, anxiety, sleep. We have lots of medications that do that really may be better served by balancing some hormones. So what are these imbalances? So I talk about estrogen, progesterone imbalances. When progesterone is low, estrogen then becomes dominant because it doesn't have progesterone to balance it. So you can have a high normal estrogen level with a lower progesterone level and you're estrogen dominant. You can have a low estrogen level with an even lower progesterone level and you're estrogen dominant. You can have a low estrogen level with little or no progesterone and you're estrogen dominant. So estrogen dominance really tends to drive PMS symptoms, mood swings, heavy periods, brain fog, headaches, migraines frequently, weight gain, bloating. It's associated with breast lumps, tender breasts, breast cancer, because you don't have that progesterone to balance it. We see more ovarian cysts. It's a higher risk for infertility and endometriosis. Certainly can lead to a low libido and regrettably miscarriages as well. So progesterone becomes the great balancer. It is really wonderful, and nearly all women that suffer from estrogen dominance will feel better with progesterone on board. Natural progesterone, and especially when it is swallowed because of the metabolism in the liver, it does induce sleep, and many women find much better restful sleep when they are taking natural progesterone. It gives us more of a calming effect. It has a GABA neurotransmitter response for those that like those nerdy things. So it is more of a calming hormone. Progesterone can also act as a diuretic. It has a very low side effect profile when taken orally. And if somebody does feel groggy from progesterone, we can always formulate it in what's called a troche. A troche is a pharmaceutical name for a lozenge. And having that progesterone in this little troche, you can slide it in your cheek and your gum and let the absorption of that hormone go in through the cheek. You're not swallowing it. Many of those women do not complain of any grogginess with progesterone when they take it that way. You can also use progesterone as a capsule or that troche in the vagina, and it acts as a suppository. And actually, that is what we do to help maintain pregnancies and give higher doses of progesterone. So like I said, if you're menstruating, you are probably making enough estrogen, but you may very well benefit from adding some progesterone in. So progesterone levels, as I earlier said, can start to wane as early as your 20s. And we certainly see this in the infertility world. Menstrual migraines, painful breasts, PMS, postpartum depression, heavy and painful menses, all of these are related to progesterone. And again, major cause of miscarriage and given in very high doses to carry and maintain a pregnancy until that woman has really had the progesterone levels come out from the placenta. I want to get back to oral contraceptives for a second, because I do want to delineate, now that we've talked about estrogen, estradiol, progesterone, these are natural hormones that your body makes. Synthetic forms of hormones are chemicals. I cannot discount the pill totally. It prevents unwanted pregnancies. It can help with significant ovarian cysts and polycystic ovarian syndrome and prevent these cysts from rupturing, which can be in a few cases even life-threatening. There are definitely reasons why the pill is a wonderful tool that we have. But we do want to be sure that that's the right thing for each woman. And we maybe want to consider, maybe we shouldn't be on it for 20 or 30 years as our only contraceptive. We do find synthetic forms of hormones in the IUDs, Mirena and Skyla. Those both release progestin, synthetic chemical progesterone, or medroxyprogesterone, into the uterus itself. So the IUD is placed in the uterus, and then the hormone is released from a little sheath that's on the IUD. We presume this is not very systemic, but it's possible. But what's nice about progestin in that kind of a device is most women do not bleed, and that is very welcome. With respect to oral contraceptives, though, these synthetic chemical compounds, they switch off your natural hormones from being produced and released from your ovaries by tricking your pituitary gland and shutting off or suppressing the follicle stimulating hormone that stimulates estrogen production, and the luteinizing hormone, which promotes the release of the egg. So that's why it works as a contraceptive. But my caution is that the synthetic progesterone, known as progestogen or progestin, is carcinogenic. And we do know that from the Women's Health Initiative of 2000, when it's used in doses for hormone replacement therapy. The other compound is an estradiol chemical called ethinyl estradiol. Can be confused with natural estradiol, which is 17-beta estradiol, so a different form, and this medroxyprogesterone. So these are chemical compounds that can be relatively safe, but we do know that under some conditions and for some women, they can be harmful. So oral contraceptives suppress our body's ability to produce our own hormones, but they also raise something called sex hormone binding globulin. Sex hormone binding globulin is a protein that our body makes to transport these hormones around the body. Our sex hormones, specifically estrogen, testosterone, and progesterone. But it really, when it raises the sex hormone binding globulin, what it really does is then it holds on to more testosterone molecules and lowers the free testosterone. This can be very helpful when I talk about PCOS, which I'll get to in a couple minutes. But oral contraceptives also prevent our ability to build muscle. So this may be an action of lower testosterone for women, but we don't want to lose muscle. That is one of the secrets to longevity, is maintain your muscle and keep eating your good protein to maintain that. But oral contraceptives absolutely do raise your risk of blood clots, stroke, and heart attack, specifically if you're over 35. I don't know where this magic number comes from, but it also is increased if you're a cigarette smoker, and that should be any age. It can also adversely change the gut flora, which then could have an impact on mental health, on digestive health, and immune health. Oral contraceptives also lower levels of free T3. T3 is a thyroid hormone that most doctors don't measure, but those that practice functional medicine, integrative medicine, hormone balancing, we all know that this is really the hormone that your cells use. And so when women are on oral contraceptives, they may actually have lower thyroid levels. This may not get picked up on a traditional thyroid stimulating hormone or TSH test, and really needs to be checked through measuring the free T3 level in the blood. Oral contraceptives also deplete B vitamins. They lower those DHEA levels, which then is probably associated with lower testosterone levels. Those two components being lower can decrease your libido, and regrettably, they also reduce levels of folate, and folate is very important for the methylation cycle in our body, something we'll talk about some other time. There are progestin-only contraceptives. And what we're starting to find, this is a small study out of the UK, but women on progestogen-only oral contraceptives do show an increased risk in breast cancer. And progestins do bind to the androgen receptor. So here again, you can't get that testosterone into the cell. Even if it's not being bound up by a higher sex hormone binding globulin, the receptor itself can't be used because the progestin is sitting in there, and they can't fit everybody in there at the same time. So alternatively, for contraceptive purposes and even for some bleeding purposes, women may have an IUD placed. So the Mirena IUD is a progestin releasing IUD, just like the Skyla. These are both IUDs placed in a doctor's office. The nice thing about these IUDs, aside from good contraceptive control, I think they're a good 99% effective. Many women will no longer have periods. The progestogen in there thins out the uterine lining so much that those women don't shed, although some women still do. And those women would probably benefit from getting on some progesterone. And then there is a copper IUD called Paragard. This has no hormones in it, so these women will have menstruation regardless of that IUD. So I want to talk about a couple of conditions that are really closely related to progesterone, especially as a treatment. But I want women to really get a better feel and understanding about some of these, because I really don't think that they're very well managed in the traditional community at all. So polycystic ovarian syndrome, I didn't look up and don't know how many women are affected by this, but it's not rare. And erroneously, it's thought of as a GYN problem because of its name, polycystic ovarian syndrome. But really at the root of this condition is insulin resistance. And the good news with that is insulin resistance is reversible. So these are positive things. Women can take this into their own hands and reverse their situations. When polycystic ovarian syndrome is not controlled, it's not recognized or addressed and treated, women have an increased risk of cardiovascular disease, dementia, and breast cancer if left untreated. And this is probably due more to the insulin resistance than anything else. But it also can have something to do with the imbalance of estrogen to progesterone and having estrogen kind of run unchecked. Many women with PCOS, not all of them, but many of them are heavier. They do carry a fair amount more fat. That fat may also be producing more estrone, and estrone has been linked with breast cancer. So lots of reasons why women can get breast cancer. And at some point in the future, I will be having a talk about cancer and prevention and how to get through treatments. So stay tuned. But with PCOS, we definitely see higher levels of free testosterone. And this is due to the insulin resistance. Physiologically, it releases more testosterone, specifically the free component. That's what can contribute to facial hair for women with PCOS and the acne that many women see. But curiously, only 50% of women ever get ovarian cysts. 50% never have ovarian cysts. They never get facial hair. They don't have weight issues. 50% of women will have infertility, but 50% won't. So these 50% of women that really don't have these symptoms, but may have a little bit of extra visceral fat, they may have a high testosterone level, they may have insulin resistance and PCOS and not be diagnosed, but end up with some of these end diseases later on in life. So usual treatment for PCOS is oral contraceptives, unless somebody's trying to get pregnant. Then we utilize metformin. But oral contraceptives can be really beneficial for some women. There are some women that just have so many cysts on their ovaries. We are really concerned about something getting so large and rupturing. That can be a very serious condition. And so oral contraceptives stop that secretion of the estrogen and progesterone from the ovaries, which then reduce the cyst formation. This will also reduce this also raises, as I said earlier, that sex hormone binding globulin. And here's where it's important because it reduces that free testosterone, which then in turn reduces facial hair and acne, which is so important to many women. So I don't discount oral contraceptives totally. I just think women need to know they do different things to your body. And there's an interesting book by a patient of mine actually worked with this doctor. She's out of, she's in Texas, but this is your brain on birth control. And Dr. Sarah Hill wrote this, The Surprising Science of Women Hormones and the Law of Unintended Consequences. So these chemicals really do other things to our body. And as she points out in this book, she's not discounting this. She was able to get her PhD. She was able to put off having her family until she was ready. So there's definitely some real reasons for oral contraceptives, but I do want people to know they're a little, you need to know all the pros and cons of them. When you talk to more functional medicine docs about PCOS, we really want to look at improving your health. And you are insulin resistant. Insulin resistance is a serious condition. We will talk a little bit about insulin isolated in just a minute, but really the trick here is let's clean up the diet. We need to eliminate our processed foods. Our processed foods, especially here in the United States, are abysmally toxic. Between our seed oils, which is highly refined and very inflammatory, the starch, the sugar that's in our food, the artificial sweeteners, the artificial flavors, the natural flavors, no regulation on that at all. Who knows what's in there? So really, I want to teach my patients to eat a more healthful diet and get rid of these carbohydrates and the bad fats, eliminating sugar and starches. That's really what this is all about. Metformin is a medication that's used for diabetics. It helps reduce glucose levels in the blood. So that helps with reducing insulin levels as well. I'm definitely in favor of using spironolactone. That is an old-fashioned, safe, interestingly enough, diuretic that is widely used for acne and can curb some of the facial hair that is seen as well. It's also very important to optimize the thyroid, and we'll get into that in just a moment, and there are separate webinars on that. And then progesterone. Progesterone can be very beneficial for PCOS patients, help them sleep, balance that estrogen. So I want to switch gears for a minute, and this is something kind of dear to my heart because I'm really touched by how poorly it can be managed in some of the general community, but yet 10 to 20% of women will experience symptoms of postpartum depression. It can generally last anywhere from 3 to 6 months. It can be very debilitating for some women and very serious and detrimental to the woman and her children, her family. 50% are never diagnosed through their providers. They kind of just muddle through it. Fortunately, 80% will achieve full recovery, but it's very scary for women to have a postpartum depression and then consider pregnancy again, because what if it's worse? What's going to happen? So postpartum depression is really kind of a pretty much an abrupt drop in both your estrogen and progesterone at the time of birth. As I alluded to earlier, the placenta makes the bulk of progesterone once that pregnancy is up and running. We may augment progesterone early in the pregnancy to maintain it. Eventually, the placenta develops, and now that's the major source of progesterone. So when we deliver the baby and then deliver the placenta, we have an abrupt drop in that hormone. And for some women, they may have very low reserves already. They may have had to be maintained in the early part of their pregnancy, and now we just cut off the reservoir that they had, and they have very little in reserve. They may have trouble sleeping, mood swings. These are more minor things, but that could turn into intense feelings of sadness, remorse, anger, worthlessness, and even suicidal thoughts and depression. And this becomes very detrimental because these women have children to care for. And sometimes that becomes a very scary position for that woman to be in. So conventional treatment, I can't discount this. There's got to be some benefit in this with antidepressants, psychotherapy, and support groups. Absolutely. The downside with these treatments is it may take weeks or months to improve. And many women don't have that time. They have a baby at home they have to care for. They have a baby that is 100% dependent on them. And they may have other children as well who also need a mother. So something that I learned very early in my training, closer to 8 years ago, and I will never forget this, and I've been fortunate enough to be in a position to utilize it for somebody I care about. Giving a high dose of natural progesterone to replace that deficiency can make all the difference in the world for these women. It can be very sedating for a few women, but I was taught, hey, start these girls off at 800 milligrams a day. This is divided doses of progesterone using that troche that I mentioned earlier. to avoid grogginess, so they're not at a disadvantage with taking care of their baby. But starting at 800 milligrams daily for a week or two, and then slowly reducing that by 200 milligram increments during the day over the course of 6 to 8 weeks. After that, it's kind of assumed after about 8 weeks that those ovaries have finally kicked back in and that woman may be producing some of her own natural progesterone. Although I have had a few patients remain on a lower dose of progesterone, which again makes total sense for symptom relief and to manage their periods. The nice thing about adding natural progesterone, this can work within days. I had somebody that I care about. Her daughter developed postpartum depression. She was placed on an antidepressant and pretty much told, this should work, but we don't know when. Within a couple days, I was able to intervene with some natural progesterone. And within about 3 days, she felt like, hey, I'm going to survive this. I'm going to be okay. And she did great. And she's a wonderful mom. I was really very grateful that I had learned this and had remembered that. And I just want women to know there's alternatives out there if you or somebody you love is dealing with this or you find yourself in that position. So endometriosis, this is another condition that is very significant, severe, can be very detrimental. It's actually a condition where the uterine lining grows outside the uterus and into the abdominal cavity or the pelvis. And then pain ensues every time that woman menstruates because the shedding of that tissue happens within the abdominal cavity. Blood in the abdominal cavity do not work well together at all. If you have blood in the abdominal cavity, it's very irritating to the peritoneum. It's painful. It hurts. And these women go through cyclical pain that can be really significant. They may have very heavy, painful periods, and frequently they have infertility issues. Endometriosis is an autoimmune condition. It can cause infertility and abdominal organ damage. There's certainly enough merit to look at autoimmune diets. The one I go to the most, and the reference I give the most, that book is out on loan right now, but is by Dr. Terry Wahls. Dr. Wahls is a very extreme example of autoimmunity. Dr. Wahls has progressive MS, and she is an internist with the VA system in Iowa. In her book, you can see a picture of her on the back, and she is seated in a motorized wheelchair. And she tells a story that she's on conventional therapy for MS. She's all hunched down in her wheelchair. And typical look, if you've ever known anybody with MS, they have a very wasting look to them. They're frequently kind of slumped in a chair because they don't have much muscle function. And she said in an interview, how the heck am I working? Like, how do I see people and how am I a doctor? How am I getting people better? And she took it upon herself to learn about the beauty and the wisdom and the power of our diet in healing. Our bodies want to heal. So she has an autoimmune protocol that is pretty severe, or strict, I should say. But she is fully functional now. She rides her bike. She has no limitations. And she did that with diet. So I always point to my patients and to myself as well, being autoimmune. Hey, if she can do that with that kind of a disease, what can I do for mine? So I really encourage women to understand that food is medicine. Food is making us sick. And you can reverse a lot of these things with dietary changes. Are they strict and a little hard? Yeah, you betcha. I'm sorry. But you can do it. And I've seen it time and time again. I've done it for myself. And it's a definite program you can follow. I also love using low-dose naltrexone. There is evidence that can be helpful in reducing the overgrowth of this rogue tissue in the abdominal cavity. And I think I've done a lecture on low-dose naltrexone. If not, we will put that in the till for later. And then adding progesterone, again, to balance the high estrogen levels that a lot of these women tend to have, can be very helpful for them. I'm going to switch gears for a little bit, and I just want to do a little touch on thyroid. I'm not going to do a deep dive here because there is a lecture, a webinar already out there on thyroid, and I encourage you to go to that if you are interested. The big thing that I want to take home here on thyroid today is there's a big discrepancy between normal and optimal levels. And most doctors really just measure something called a TSH. TSH is a thyroid stimulating hormone that comes from your pituitary gland. And essentially what it's telling me is what your pituitary perceives as enough or not enough thyroid as it goes through the pituitary gland. These mechanisms were very powerful when we were cave people. We did not have electric lights. We didn't have EMFs, the microwaves in our phones. We didn't have any chemicals in our world up until a decade ago, maybe. So these mechanisms in place worked great. If your pituitary gland noticed that your thyroid was down, it just gave you more stimulating hormone and the thyroid kicked more out. We had great mechanisms to utilize that. We don't anymore. We're pretty toxic. And many of us don't fit the mold with that level. We may have many, many symptoms, but the TSH looks very normal on paper. And there's over 200 different symptoms that have been associated with thyroid dysfunction. The most common that people think about is they're tired, they're gaining weight, they can't lose it, their hair may be brittle or they're losing it. They may have cognitive issues, cold intolerance, and infertility. But plaque can be associated with it, heart palpitations with low thyroid, muscle wasting. There's a number of things that we just don't really associate with thyroid or really think of it in traditional medicine. Probably one of the most important things is to understand you need to measure the free T3. I never learned about measuring free T3. I learned about free T3 and reverse T3, but we never measured it. Now I won't treat somebody without measuring their free T3 because I want to know how low it is or how high it is. What do they need? And I think we should all, as providers, be suspicious that if somebody has these thyroid issues, they may have an autoimmune condition called Hashimoto's. That's important because if you're autoimmune, you have a higher risk of developing another autoimmune condition. I've had 3. Pretty much everybody in my family has had at least one. My mom had 2. My dad had 2. So we really need to be on the lookout for these things so we can guide women into better health journeys to avoid getting downstream problems. And the way you do that is by checking something called a TPO or thyroid peroxidase antibody or a thyroglobulin or TG antibody. So again, infertility is a big problem with thyroid, and regrettably, many people only check this TSH level. TSH has got a really wide range. 0.4 is normal, so is 4.5. So if I'm only checking a TSH and a woman can't get pregnant, I may miss that she makes a lot of reverse T3 that blocks your T3 in the cell. I may miss that her T3 is quite low and she has something called low T3 syndrome. I may miss that she's got Hashimoto's. These Hashimoto's antibodies make getting pregnant a lot harder. So really, we need a full panel. We need to look for all these things, and then we need to know how to interpret them, because sometimes labs come back in the normal range, but they're at the low end of the range, and that patient may be a very disadvantaged person because of that. So lab values are not always the best guide once I'm treating somebody for thyroid, but they do give me a good window into seeing where these levels are on their own. So improving thyroid function, I like to look at this aspect with my younger patients. I certainly use thyroid. I preferentially like natural desiccated thyroid. It comes from a pig, gives you T1, T2. We didn't talk about those, but also this T3 and T4. But I really think it's important when I do talk to people in their 20s, hey, let's talk about cleaning up your diet. It's a great time to do that. That will improve your thyroid function. Avoiding chlorine and fluoride in your water. Get a good water filter. There's even these little filters out called Go Pure, and you can drop them in a bottle of water. It cleans out fluoride, chlorine, 99 different contaminants. They're good for about 6 months use. It's pretty cool. Getting rid of wheat, especially in America, gets rid of Roundup. But it also, if you remove baked goods from your diet, you're also removing bromine, and bromine can block thyroid just like chlorine and fluoride. Iodine supplementation can be very beneficial for a number of people, and that's a great place to start, especially if a thyroid is just a little sluggish. Let's see if we can get a better conversion of the T4 to T3, get that T3 that your cells need. But when I really need to, I do use natural desiccated thyroid as thyroid replacement. And you can definitely see more information about thyroid on a past webinar. I think I did that last year. The other hormone that we want to touch on here is cortisol. So cortisol is released from the adrenal glands and helps to regulate stress response. As I mentioned earlier, the truck coming towards me as I'm crossing the street, it's intended for short bursts, minutes of energy. It suppresses inflammation. It boosts immunity. All these are things that we need in times of stress. But regrettably, cortisol is secreted for real stress, the truck coming towards me, and perceived stress. Oh my God, I hope I don't get in an accident tonight. Oh my God, I hope my family is okay when I get home. Oh my God, I hope we don't get in a fight tonight. Those are all things that can raise your cortisol level, in addition to just life in 2023. So most Americans, unfortunately, live in very high stress levels, and our cortisol levels are high. Cortisol helps to regulate your blood pressure and increases your glucose levels. So we want that if I'm running across the street. I need a quick spurt of energy. I need my blood pressure, believe it or not, I need those blood vessels kind of tightened down so that I've got all this energy and response in my muscles. So these are all good things. Cortisol helps control your sleep cycle, your circadian rhythm. But the problem is when cortisol is out of control and it's persistent, then we have a real problem. Now it's damaging to my cells. It stimulates that increased glucose level, which gets us high insulin levels, which we'll talk about next, increases visceral and abdominal fat. It actually blocks my progesterone receptors. So I can't even get what little progesterone I have into the cell. It suppresses the immune system. It inhibits the conversion of that T4 to T3. And then it increases when we start going into perimenopause and menopause. This is why women start to gain weight. We're packing that on because of cortisol. That's the hormone that we use instead. So really controlling cortisol levels, that is a factor of managing our stress. There's a whole lecture on stress, a webinar that my colleague Becky Barkey just did this week and should be posted soon. So I really encourage people to keep getting a better grip on their stress levels and how to lower those for better health. I'm going to touch on testosterone now. I don't give a lot of testosterone to younger women. I would say I utilize more testosterone in the 30s and 40s, not generally for 20-year-olds, just doesn't seem to come up. I see more thyroid issues for those women, progesterone, low progesterone levels. But testosterone, regrettably, is thought to be just a male hormone, but we make it too. Every cell in our body responds and has a receptor for testosterone. And as I said earlier, it's essential for ovulation. We won't ovulate without it. So testosterone is a wonderful hormone in the fact that it increases bone growth and density, increases muscle mass. And when we increase muscle mass, it's more metabolically active. So you're going to help reduce your visceral fat as well. Testosterone also is great for raising our libido. It improves our mental clarity, our focus. It helps reduce anxiety, depression, post-traumatic stress disorder. Testosterone as a supplement can be amazing for some women. Here's a little diagram or illustration of all the different places where testosterone has a role. So some of the other things that it talks about is increasing skin collagen production. So it's good for your skin, influences the reproductive tract, as I mentioned, and muscle mass. It is also anti-cancer for breast. So there's a number of studies out now where there's a surgeon out of Florida, I think she is, Dr. Glazer, who has actually shown that using a testosterone pellet in a tumor in the breast will help shrink it. So there are definitely some apoptotic, we call that, cell killing capacity of testosterone that has been shown and that we see in the literature in studies. So naturally, testosterone is converted from precursors like the DHEA I mentioned, and then 50% of it is converted from cholesterol in the adrenal glands and the ovaries. You can take DHEA, and I'm not anti that at all, but the problem with DHEA is many younger people are very sensitive to DHEA supplementation. They have excessive hair growth and breakouts, and that is not what most 20-year-olds want. So if we supplement with testosterone, we can use a cream, a troche, or pellet. I'm not a fan of oral testosterone. What I do like about the creams and troches is they can be easily adjusted for the person on their own. Pellets have a little more permanency to them. They're usually good for 3 to 5 months. So I can't take a pellet out, but you could add or take away from a troche or a cream. And those are definite options. And there is another webinar that concentrates really on hormone health, bioidentical hormone therapy, I should say. And that goes into a deeper dive of the postmenopausal use of estradiol and progesterone, but there's a large body of that goes into testosterone as well. So I just want to finish up with insulin. Insulin is probably one of the more important hormones that we need to talk about and think about. Insulin is a peptide hormone, so it's a super small hormone, or a super small amino acid. And what am I trying to say? It's a small hormone. Let's stay with that. It's produced by the pancreas, and its job is to maintain normal levels of blood glucose. So it actually allows our cells to use glucose as energy. You take in some carbohydrates, it utilizes it through an energy source, and that promotes cell metabolism and growth. It is actually designed to spike and then return to baseline. And that's not what happens for most people. Regrettably, glucose in high levels is toxic to our blood. So we have this mechanism in place. When you take in a large amount of glucose, your insulin is there to shuttle that stuff out of your bloodstream. And it's got 2 places it can do that. It can shuttle it into the muscle, and it can shove it into fat. So that's why insulin is really there. It's for our use with this energy source, but it's also there to save us from dying if our glucose gets too high. Regrettably, in the United States and in many places in the world, we follow a very high carbohydrate diet, the SAD diet, the SAD diet, the standard American diet, very high in carbohydrates. With this diet, we release even more insulin into the bloodstream in higher levels and more persistent levels to remove that glucose. Insulin's not checked very often. You need to be fasting for it, but we really tend to focus more on diabetes. And I don't discount that diabetes is a serious condition, but really you could have normal levels of insulin, I take that back. You can have normal levels on Quest's labs, less than 19, and have these persistent insulin levels and end up with all the same diseases as diabetes with never becoming diabetic. It's really kind of strange that level is optimized through Quest labs if it's less than 19.5. The colleagues that I follow, the insulin experts that I follow, Ben Bickman, Jason Fung, these guys all say, hey, we need this level under 6. This is silly. We are just normalizing these high levels of insulin, but they are really driving many disease processes. Probably the one that's most important here is insulin resistance is at the basis of PCOS. And that's why it is so important to break that cycle, get that glucose under control, because this insulin resistance is maintaining weight. It's increasing visceral fat, can lead to type 2 diabetes. And as I said, some people never become diabetic. They're just insulin resistant their whole life, and they can have all the same diseases like neuropathy, hypertension, arthritis, dementia, cancer that go along with diabetes. I'll wrap up hormones-wise with just a little statement about vitamin D3. Vitamin D3 is actually a prohormone. It's made from cholesterol. We have a very broad range for vitamin D, 30 to 100, but really the optimal range is 50 to 80. So you do want a higher level of vitamin D for your immune health, your bone health, mental health, depression, anxiety. All these things are helped with vitamin D supplementation. And I bring it up really because it's a hormone, not a vitamin. So why doesn't your doctor talk about this stuff? Why don't they know? New treatment and drug information, as well as the continuing medical education that we take as providers, most of those are underwritten by big pharma. And if that's the case, they're promoting pharmaceuticals. So there's a confirmation bias out there as well, interpreting data and info that aligns with previous beliefs. And so many doctors just keep perpetuating what they learned. They really don't move on. There's also quite a delay in information. Something's published in a very well-respected journal may take an average of 15 to 17 years to publish, between publishing and actually using that as a general application. So our doctors are really smart. They're smart about the things they learn. They don't learn about things that are outside that. And it's really hard to change that because this is new ideas. Those are hard to evolve. So now what do we do? So a couple things we can do to boost and balance your hormones. Get in a better eating habit. You are eating to build a better body. You are nurturing your body. Food is medicine. So buy organic when you can. Eat whole vegetable and fruit along with wild and pasture-raised protein. And drink filtered water. Right there, if you do that, you will change outcomes on so many levels. You want to remove fragrances from your personal space if possible. Fragrances are toxins to many of us, and they offset those hormones. You want to clean with non-toxic cleaners like hypochlorous and Branch Basics are two products that are non-toxic and very effective. And then ditch the plastic food containers and start using glass because they are just leaching hormone disruptors into your food. We want to eliminate sugars and high glycemic index foods. These sugars spike, and then your insulin spikes. That lowers your T levels and increases your cortisol. So right there's a good reason to get rid of sugar. I have a problem with sugar. I'm still working on it. It's getting close to getting rid of it. Eat more high quality protein to build better muscle. So you want 100% grass-fed beef, pasture-raised poultry, and wild-caught fish. And then eat high quality fats to build better cells and receptors. That's your avocados, olive oil. Make sure it's high grade olive oil. A lot of it's tainted. There's a whole lecture about food as medicine that you can look up. You want grass-fed butter and you want grass-fed ghee. And then optimize your vitamins B, C, and D. You want to heal your adrenal glands. That's where the adaptogens ashwagandha and sea salt can come in. You must start to get into better sleep habits. This is when we make a lot of our hormones and we actually clean up a lot of the garbage that we've made during the day. So we really want to sleep in a dark room without distractions. I'm not a big fan of sleeping pills unless they're really needed. They inhibit your REM sleep. They may give you an extra 30 minutes, but you're not getting good restorative sleep. And then try to practice yoga, get better exercise, go out and take a walk, try some yoga, deep breathing, Tai Chi, meditation. All these things will reduce your cortisol and raise your other hormones. And then start to cook with better spices. Get some turmeric, thyme, oregano. All of these raise your that's a notation for progesterone, your P4 level. Selenium also raises P4 levels and is a great antioxidant, also can be very helpful for your thyroid. Avoid overeating, which lowers progesterone. Vitamin C is an amazing antioxidant, which can help balance your hormones. There's something called DIM that we use in our office to help with hormone balancing, and then iodine, as I talked about earlier. And then lastly, I want to bring up hormone disruptors. These are chemicals and substances in our environment that either mimic hormones, block hormones, interfere with hormone production, or modify the body's sensitivity to the hormones. These are our microplastics. This is our plastic garbage. This is the BPA in our water bottles and canned foods. They've taken the BPA out of water bottles, but it's still in a lot of canned foods. So it's best to not eat as many, unless it says on the label BPA free. And then these forever chemicals are a real problem. That's the chemicals PFAS, PFO. They're in Teflon and Scotchgard. They're in flame retardant, waterproofing clothing. And the problem with these is they never go away. They disrupt our hormones. But chemical companies change one little configuration in that, and they get away with it until they caught, and then they ban that one. So it's just a revolving circle. There's hormone disruptors everywhere. So there's lots of things in factory-made foods. Atrazine is an herbicide. Dioxin is a byproduct of our industrial chemical world out there. And so really avoiding these factory-made foods are really in your benefit. Phthalates and parabens are found in many personal care products. You can find them without, so I encourage you to look at those. And then EMFs from our phones and our devices are really radiation. So avoid carrying your phone in your bra, next to your breast, or in your front pocket, especially for our guys that's sitting right next to their testicles. That absolutely affects sperm and testosterone, no doubt about it. That has been shown. So, and then put it on airplane mode if you sleep with it next to your head. Lastly, seek some help if you can. Find a GYN who has learned about bioidentical hormone therapy and is better well versed about using natural progesterone. Find a hormone specialist like myself. I love seeing younger women because they really have been done a big disservice in not getting these hormones regulated. Functional medicine provider is a great resource as well. You can always ask your provider to get specific tests, so become savvy and learn what you can do to help yourself. Learn as much as you want to learn. This information is out there. It is not hidden. It's not a secret society anymore. You get to learn whatever you want, and I can help you get there. We know that things are healing and your hormones are better balanced when, as this little poster shows, you're managing your emotions, you're setting and maintaining boundaries, you're accepting support, personally validated, you're forgiving yourself, and you're breaking old habits. All of those things are things that help us heal. Please be in touch if we can be of any help for you here at Basana Health and Wellness, and hope this was helpful.